Good afternoon, colleagues. My name is Dr. Momin Atiyeh. I'm an associate professor at Mohammed bin Rashid University of Medicine and Health Sciences in Dubai, United Arab Emirates. It's a great pleasure for me to be the moderator of today's webinar. Today's webinar is organized by Index in cooperation with ADIC and Waterfall. Our speaker today, Professor Marcelo Faveri, is going to talk to us about guided bone regeneration. His lecture is going to last for 1 hour and 15 minutes. This will be followed by some time to address your question. Professor Marcelo is a periodontist. He's holding a PhD in Biomedical Science from University of São Paulo, a Post-doctoral Fellowship from Harvard University. He's actively involved in teaching and research in Sao Paulo in Brazil, and serves an associate professor of master and doctorate degrees in periodontology and oral implantology. Professor Marcelo has published over 100 papers in international peer-reviewed journals. His work is very well cited, and I just checked his H-index this morning, and it has an astonishing H-index of 43. Please feel free to post your questions at the Q&A icon. We are going to address your questions at the end of the lecture. With regard to the CME certificate, you can follow a link that will be posted at the end of the lecture. Without any further ado, Professor Marcelo.
Good afternoon, everyone. For me, it's a big pleasure to be here and even in a webinar to talking with you guys from Dubai and around the road. I'd like to say thank you from the guys from AADC Dubai and everyone that are doing and promoting these webinars. Even here from Brazil, we would like to say that for us it's again a big honor to share some knowledge and to share some clinical experience in this topic that we select to give to you during this day, and I hope that at the end we can conclude some important things in these two topics that we choose to talking with you during this afternoon in Dubai and during this morning here in Brazil. So we're gonna talk a little bit about resorbable and non-resorbable membranes in advanced bone reconstruction, and how to select them. This is a very important topic in our practice, and I think that everyone that works with implant dentistry have this kind of question sometimes during our practice. And I'm also trying to show you some factors and some points that we must avoid during guide bone regeneration. Like we said, my name is Marcelo Faveri. I'm from Brazil. I'm working in University, Guarulhos University. It's a city around Sao Paulo, the big Sao Paulo. So I hope that you can enjoy this time with me. I think that everyone that are attending this webinar maybe works with implant dentistry, and we know that there's a very close relationship between implant dentistry and guide bone regeneration, because like as we can see here in this screen, this is my reality, and the most part of my patient, they present some kind of bone defect, and we need to know how to deal with this kind of patients, because most part of this patient comes to our office and they want to have some kind of rehabilitation, oral rehabilitation, and normally they want to place implant. But if I don't have a good bone quality, if I don't have a good bone thickness, and if it's not possible to place the implant in the 3D right position, we're gonna have problem, and sometimes it's impossible to place implants in this situation. So again, it's important to understand and to know and to work with bone reconstruction when we are working in implant dentistry specialties. And when we talking a little bit about GBR, it is important to understand the principle of this treatment. And the principle of this treatment is to create a right space for my bone graft, to create and to have a barrier or a membrane that's gonna stabilize this bone graft and will avoid the collapse of my bone graft, and also avoid that other types of cells, mainly the soft tissue cells, comes into my graft, and instead to have and create a new bone, we'll create like soft tissue, and normally we have a fibrosis and not a real bone. So a correct barrier or a correct membrane choose, it's one of the key for this a good outcome and a good clinical outcome to our GBR. So when we thinking about membrane or barriers, we have basically two types, right? We have the resorbable membranes and we have the non-resorbable membranes. Both of these types of barriers or membrane, his aim is to create a space and to provide soft tissue isolation to our area of bone regeneration. And therefore, we'll create a right space and a blood clot stability to this area, and give time to have a good healing, to have a recruitment of mesenchymal cells from the periosteum, from the bone marrow, and therefore we have a bone forming cells. So again, how to choose these two types of membrane? What is the best one, or is there a best one membrane that we can use in our GBR procedures? This again, it's a very common doubt in our daily clinic. It requires a good biological concept in order to use this kind of membranes, and both has advantage and disadvantage in order to promote our bone regeneration, right? So let's see what we can get. Before we start specifically with a non-resorbable or a resorbable membrane, it's important to understand that we have normal general criteria to choose this membrane. And this general criteria should be fulfilled for the use of this membrane. And all of these membranes should present a good biocompatibility. That means that promote a host tissue integration with no body reaction, should maintain a good space integrity and wood stability. It should be easily to use and handle it with this membrane, because normally this kind of surgical procedure, it's a little stressful. And again, if you have some tools that it's hard to use, normally it's not good for our surgery. So we need to have something that is easily to handle it. And normally the most part of the barriers of the membranes that we have nowadays in the market present this criteria. It's important that this membrane or barrier enhance the duration of the bone formation. It means if I'm working with a resorbable membrane, it should be give time to the new bone formation. That it's the time of the formation of these cells or the maturation of these cells. It's completely different with the soft tissue cells. So again, the rate of the resorption of this collagen membrane or resorbable membranes, even if it's a synthetic membrane, should be also understanding, because if you have a fast rate of resorption of this membrane, normally the quality of the bone or the new bone formation is not so good. So this, again, should be some general criteria that you need to understand before to choose the right membrane. So when you are talking directly with these two types of membrane, and here we are going to focus now with the resorbable membranes. Like I said, both has advantage and also disadvantage. When we are talking about the advantage of this resorbable membrane, and normally it's the most part of the dentist, I don't know in Dubai, but here in Brazil, they prefer to work with this resorbable membrane, and we are going to talk a little bit about it soon in the next slides. But the means and the reason that they normally prefer this resorbable membrane, it's about because this decreases the patient morbidity. It's a very important. Nowadays, we know that the personal opinion from the patient about our procedures, it's a very important thing to understand and to collect data in our clinical studies. So every time that you read a paper, in a clinical paper, normally nowadays they have the evaluation and the analysis of these clinical procedures based on a patient outcome and a patient perspective. So again, when we compare the use of resorbable membrane with a non-resorbable membrane, normally we have less morbidity and that it's good for our patient. Another advantage of this resorbable membrane, it's we don't need a second stage surgery to remove this membrane, right? We simplify the procedure. And again, we always need for guided bone regeneration resorbable membranes that presented a lower rate of exposure, and again, a lower rate of resorption. When it goes to the disadvantage of this membrane, again, when you don't know the duration of the function of this barrier, it's going to be a problem. Normally, when we worked with native collagen membrane, we know from the literature that normally these pericardial membranes, even from a bovine or a porcine animal, okay, or search, sorry, we have normally around 6 to 80, and some studies said to us around 10 weeks of resorption. That means that it's a good time to, and we have a good period of function of this membrane. But again, when you are talking and you are dealing with big reconstruction, normally in order to support that membrane and to avoid it collapse, normally we use, and sometimes it's indicated to use tendon screw technique in order to support that collagen membrane. And again, another problem that this collagen membrane or resorbable membranes could have, it's the micro movements because the stability of this membrane. So again, when we work with a soft membrane, so a resorbable membrane, it's very important to do a good fixation of this membrane. And we're gonna talk a little bit more later, but one of the points of this collage membrane, independent of your the defect that you are working, it's also important to have some kind of fixation, even with screws, even with pins, or even with a suture. It depends of the size of my graft and the size of my defect. So when we are talking about resorbable membranes, we have some synthetics ones, so from PGA or PLA, or again, collage membranes, and mainly native collagen membranes from pericardium that we know that it's the best ones in the market, and different companies present this kind of collage membrane. Otherwise, when we are talking about non-resorbable membranes, again, we have advantage and disadvantage on this kind of procedures. But the main advantage of this kind of membrane or this kind of barriers, it's the mechanical stability, because it's like it's a hard tissue, it's a hard biomaterial that have and give to us a good mechanical stability when we compare with collagen membrane. Most of these non-resorbable membranes present an excellent biocompatibility, and again, promote a wood stability, and it's a very higher literature on this kind of membrane, and all of this literature said to us that this kind of membrane or barriers present a good and a successful outcome for bone regeneration. And one important thing in this non-resorbable membrane, it's also its plasticity. How we can have a shape and control the adaptation of these barriers. So when we're talking about some titanium mesh, some PTFE membranes, it's easily to handle with this membrane also, and it's also to have a good contour and have a good adaptation independent of the bone defect and the size of this bone defect. However, we have some disadvantage using non-resorbable membrane, and the literature bring to us that the risk of exposure, it's very higher. It's not higher. It's when we compare with collagen membrane, it's a little higher. It's around nowadays. We're gonna present this data, but it's around 16% of exposure. And when we work with collagen membrane, it's around 10%. So it's a little more higher than the collagen membrane. But when we know how to deal with this, when you know how to work and we have a good curve or learning using this non-resorbable membrane, normally we have similar rates of exposure. Again, when we have this exposure, of course, we have a higher risk of infection, and all of these membrane, different than collagen membrane that we can fixate, depend of the size of the defect with sutures. In this kind of membranes and barriers, we need to use like a fixation with screws or with pins. And the last disadvantage that we have in our practice is that we have a second surgery, because we need to remove these barriers after 6 to 9 months, depends of the case, depends of the age of the patient. But again, we need a second surgery site in order to remove this kind of membrane. So when we have all of these things in our mind about the advantage and the disadvantage of both resorbable and non-resorbable membrane, we can start to thinking a little bit in our GBR. So I have the understanding about my barriers, how to put this in practice. Before we start to talk a little bit about the clinical techniques, it is important to understand that independent of the technique, the biological concept should always be respected. And this is a very nice paper published by Dr. Young in 2006. We call this PASS principle. It's 4 factors and key factors that should be our guidelines for ever guide bone regeneration. It means that independent of the technique, independent of the membrane, independent of the area that we are working in our patient, these 4 keys should be always respected. So let's see individually this. So this is a table that in the left of the screen we have the principle, and in the middle and in the right of the screen we have the purpose and the outcome of this guideline. So the first one, it's always we need to have a primary wood closed, and this is depend my flap design, the incision design, because how I will release this flap, open this flap, maintain the periosteum integrity, and at the end we need a tension-free flap in order to have a good close of this flap, and therefore we're gonna enhance our bone regeneration. We need to give to our the area that we want to graft. We need to promote and to provide nutrients and oxygen for that cells, right? So in order to have this, we normally promote what we means angiogenesis, and we do this like during our GBR, small rows in the cortical bone. We means that we know the name of it is corticotomies, in order again to enhance and to provide nutrients for the area that we are doing our bone reconstruction. And the last 2 principles means around the functions of the barriers of the membranes, that it's create and to maintain the space, right? So to provide and to have a good space in order to prevent collapse of our graft and maintain the integrity of that graft, it's again one of the most important things in GBR. Okay, so and we're gonna talk a little bit in order to choose, and I'm gonna show you some clinical examples and clinical cases about both barriers, and trying to help you to choose the right barrier for your GBR. And the last one is the stability of the wood cloth. We need for this to promote the blood clot formation in this area. And again, a primary wood close, it's fundamentally to have the stability of this blood clot. Always regeneration and the soft tissue or in the hard tissue, it's related with blood clot formation and blood clot stability. So we know, and we call this PASS principle. And again, even we are working with a resorbable or non-resorbable membrane, we need to follow these guidelines, these principles that was published again 14 years ago. And even today, we are sometimes we forgot these principles. So again, if you want to have a good outcome in your GBR, follow these rules, and your chance, our chance, gonna be higher. So let's start to talk a little bit about some techniques. And the first one I'm gonna show you, it's the using a non-resorbable membrane using a titanium mesh, okay? And we're also gonna show you the use of collagen membrane in a technique that described by Stephen Urban in 2011 that we call this sausage technique, that normally we use this resorbable membrane. But again, before we start the technique, some important issues should be understood in order to choose the right technique and then in order to choose the right membrane. So the first issue, it's about the regenerative potential of the bone defect. So nowadays, the literature bring to us some information. So if I can have a bone defect that I can and I need to have like a vertical and a horizontal bone gain, right? Sometimes it's just horizontal, or sometimes it's just vertical, and sometimes we have the combination of both. And again, sometimes we need a small bone gain around 3 millimeters, a medium bone gain around 5 to 6, and a higher bone gain more than 6 millimeters. So when I combine these two informations, horizontal and vertical bone gain, and the amount of bone that I need to rebuild or reconstruction, we can start to choose the right membrane. Even when I have, okay, and it should be also pointed here that vertical bone gain, it's more difficult than horizontal bone gain, and large and severe bone defects, so more than 5 millimeters, more than 4 millimeters, it's more difficult in terms of the potential of the regenerative bone defect. So when I'm talking about big defects that I need a lot of vertical bone reconstruction, right? More than 4 millimeters. And when I need more than 4 to 5 millimeters in an horizontal way, normally we choose a more stable barrier. So we are talking about non-resorbable membranes. When I have less defects or lower defects, almost 2 to 3 millimeters vertically, 3 to 4 millimeters horizontally, and I have a good shape in this bone defect, normally we choose, or we can choose, a collagen membrane. And if you want to use a collagen membrane in big defects, normally the literature bring to us that we, like I said before, to use like a tent screw techniques, right? So the potential of the regenerative, it's one of the things that we need to understand. Again, and the choose of this membrane will promote a good or a not good graft stability. That it means are related with our clinical outcome. Another important thing, it's the periodontal biotype. In 2018, we changed this term biotype to phenotype. So it means the thickness of the soft tissue. So when I have a thin periodontal phenotype or a gingival phenotype, and I decide to use a non-resorbable membrane, I need to be careful about it, because the risk of exposure of this non-resorbable membrane, it's higher. So sometimes I need to go one step back. Sometimes we choose to do little soft tissue measurement in order to increase the thickness of the periodontal phenotype. And after that, we decide and we choose to, and we start to do our GBR, right? And the last one is to be careful with the sutures, because we always need attention-free closure. And sometimes we don't care about suture. That it's a big error in our surgery, because we are focusing our flap, we are focusing on which kind of bone we're gonna use, we are focusing on which kind of membrane we're gonna use, but we don't care about the suture. And the suture is one of the keys for have attention-free closure. And again, all of the steps, it means all of the steps of a GBR should be respected. Before we start to go to the literature, to the techniques, the last point that I would focus with you guys, it's the right combination of bone grafts. Normally, we know that we can use 100% of autogenous bone. Sometimes we can use 100% of xenographic bone, and normally my first option it's a bovine bone, right? This is what we have here in Brazil, and good companies on this, and this is what we have most studies in the literature. So normally my preference is to work with bovine bone or a mix, an association with these autogenous chips or with our bovine bone. We have different combination of this mix with autogenous and xenographic bone. The most common that we normally know it's the 50% of both, and this is it's higher promoted by Steven Urban and works very well. We have a lot of literature on this, but I prefer to instead to use all of the time using 50% of both xenographic and autologous chips. I prefer to go to the literature and understand some points important. We don't have randomized clinical trial to test in this different combination with autogenous and xenographic bone. Instead, we have one paper on this, but here I select 3 papers that I would like to discuss with you. The first one, it's published in 2008 with Francesco Pieri. This is not a randomized clinical trial. Actually, this is a case, it's a control, it's a prospective study. It's like a case series analysis that they use, they select some patients that presented around 2 millimeters of thickness of bone, and they need vertical and horizontal bone augmentation, and they use a mix of 70% of biomaterial and 30% of autogenous bone, and they place implant in this patient, and they follow up these patients during 2 years. So in all of this time of the following up of this patient, they have 100% of survival of this implant, and they have a bone gain even horizontally and vertically bone gain around 4 millimeters. So we can see that even when we use 30% of bone, we have good outcomes to our patients, and we have, again, a good stability of the implants that we placed. And a more recently study published from Anne Mordenfeld that it's a randomized clinical trial that these colleagues, these researchers, they compared two combinations of, again, autologous bone, autogenous bone, and biomaterials. And here they have the first combination, it's 90% of biomaterials and 10% of autologous bone. And they compared the clinical and the histological analysis and results from another group with 60% of biomaterial and 40% of autologous bone. And when they compare the bone gain, the bone area, the soft tissue area, and the percentage of particulate of this bone inside of this graft area, no difference were observed between these two groups. So both concentration can be used to our patient. Even, okay, in the histological analysis, they didn't found difference between these two kind of different. The only difference that they found is a little more stability in the volume, okay, after 7 months when they combined 40% instead to 10% of autologous bone. So we have two different papers here, different from the concept of Stephen Urban, that it's worked very well. But again, I always want to show these papers because we need to focus and to have clinical trial on this. So in our university, we are trying to promote some studies on this. We have some ongoing studies. So I don't have the data now, but again, maybe we don't need all the time 50% of autologous bone. If I don't have, and if I don't need 50% of autologous bone all of the times, I will have a less morbidity to our patients. Even when I use non-invasive methods to collect this bone, with bone scraping, with ACM drills, and different stuff to collect this bone. And in the right of the screen, we have a good paper, but it's in an animal studies showing us what the importance to combine autologous bone with xenographic bone, with biomaterials. Here they mixed only 25% of autologous bone with a bovine bone. And 60 weeks after to our graph, they found that the healing, the percent of new bone formation in the group that was mixed with autogenous bone are better. So what means, why we normally use this autologous bone to our biomaterial? In order to enhance the biological capacity of our bone graft, because it's important to understand that this biomaterials has only the capacity of the osteoconductive approach. And we need to have growth factors in order to enhance our healing in our bone formation. So when I mixed this autologous bone to my biomaterials, I have a different biological signature to my bone graft, and normally I enhance the healing of this bone. But again, in my opinion, depend of the defects, depend of the thickness of the initial bone defects, we can decide if I'm gonna use more or less than 30% of autologous bone and mix this with my xenographic bone. So when we can see here in the screen, when I have a thin thickness, no medular, no spongious bone, like in the upper side of the tomography here, normally my decision is to go more close to the 50% of combination. But when I have in the other part of the screen a good thickness, a higher thickness, when I don't need to have a higher vertical bone gain, and again, around 3 to 4 millimeters of horizontal bone gain, maybe I can mix this with less autologous bone, around 30%, based on the last two papers that I show you, and based also in the animal studies that I showed. So let's go to the some clinical examples. So here we have, gonna start with the titanium mesh. It's also important to have a good flap design in this kind of approach, even if you are working, and here we focus on the anterior part of the maxilla, but even if you are working the posterior part of the mandible, that normally it's a very difficult area, but when you follow some rules, normally we have more successful or good outcomes. So here, normally we do like a supracrystal incision, and we move far 2 tooths away from the area that I want to graft, and we do our vertical or reducing incision 2 tooths away from this area. Normally in this first tooth, we do like a split flap in the interproximal papilla in order to maintain the volume of this papilla, and in the palatal area, we do 2 little vertical incisions, but we maintain, okay, the integrity of this interproximal papilla in order to enhance the blood supply and the vascularity of this interproximal papilla, in order to avoid to lost the volume of this papilla. That's maybe that sometimes it's a big issue in terms of aesthetics. So let's see a case. So this is a patient that comes to our clinic in the university at Guarulhos. This patient wants to place implant, and when we see in the CBCT tomography, we can see here that we don't have a bone quality and a bone thickness to place the implant here. So we decide to do a GBR in this patient. So we can see here the loss of volume. After open the flap, we have this condition, and let's see the video of this surgery. So we have more understanding of the clinical procedure. So we have a supracrystal analysis, incision, sorry. So we can see here that in the interproximal papilla, we do like a flap, a split flap incision. So we do our vertical incisions, and we start to open the flap very gently, very delicately in this area, because we need to maintain the integrity of the soft tissue. We can see here that this patient presents a good gingival thickness, a good keratinized tissue. So normally we have a good stability of the soft tissue in this kind of patients. So we start to open the flap. In this area, we need a full flap, thickness flap, but we have to maintain the integrity of the periosteum. So we're gonna move very gently this flap.
I think we are losing your voice.
So we can see here, we open the flap, but you can see that the mobility of the flap, it's very hard. So we start to cut a little bit the periosteum, but in the apical part of the tissue, because we don't want to cut this very close to the area that we're gonna graft, because we need the stability of this periosteum. We have mesenchymal cells in this periosteum that enhance our bone formation. So we can see here the flap starts to have more mobility. one line of incision, only in one plane of incision. This is a very important, and you can see here how amount the flap comes to the incision part of the tooth. So we can see that we have a good mobility of this flap now. We should take out all of the soft tissue in this area of the bone. So we can use like this in a drill, but we should have a flap elevator and scrub this bone, that's okay. But no soft tissue in this area. So we start to promote angiogenesis, like we said before. So small rows in the corticotomy, in the cortical bone, so promoting a corticotomy. We need to see bleeding of these rows. So here we have a titanium mesh. This is a titanium mesh that present a small perforation around 0.15 millimeters. So in this case, we don't need a collagen membrane over this membrane, this titanium mesh. So normally nowadays I change my way of working. Normally nowadays I fix in the apical part, in the vestibular part, and after I move the titanium mesh to the palatal, but doesn't matter. Both option, it's good. So your fixation with little screws in the palatal, we feel the bone defect. Here we are using 70% of bovine bone and 30% of autologous bone. So since we finish, normally we put a little more bone, around 1 millimeter than the result that I want, because we know from the literature that normally we lost around 1.2 millimeters. We need to cut. We don't have this sharp edge in this titanium mesh, because if you have this sharp edge, normally we have some exposure in this area. So we need to cut to fix everything. So two screws we're gonna place two screws in the apical part, so we have the titanium mesh completely fixed, right? And in this case, we decide to use also a collagen matrix in order to enhance the soft tissue. So this is a collagen membrane, but it's not all of the case that we use this matrix. But when you have a thin periodontal phenotype, it is good. So we cover this after fixation, and we cover this with PRF membrane in order to enhance the soft tissue healing. And we fix everything. So we start to fix. Normally use maintenance sutures, 2 or 3 in this anterior area. After that, we use simple sutures. And you can see here that the flap, it's very stable. This is a very important point to see, okay? And this is after 6 months. We can see the bone, the amount of bone that we gain, it's around 7 millimeters, okay? So here we have 1.3, 1.5, now we have around 7. And here we have the CBCT tomography, and we can see here that a bone gain around 4 to 5 millimeters. That again, we have now space and bone to place our implants, right? Let's see another case. And here, it's a case that I did with 2 PhD students of mine, Dr. Caio Miranda and Dr. Gisele Araújo from Goiânia. But here we use, in combination with this titanium mesh, we use 10 screws, the new ones that we have here in Brazil, that we can have also the stability of the membrane, but you can also fixation this membrane in these non-resorbable barriers. So here it's the same principle that we talk. We collect the bone from the sheet. Here we're using a ACM drill. We combination this with PRF, with IPRF. So this is the 10 screws. So to have a free tension flap, so you can see that we have a good mobility of this flap. So we do like a stick bond, okay? Combination the PRF, combination the autologous bond. So we have these bond blocks that is very nice to handle. When you are working with particulate bond, this is a good approach to use because it's very easy to adapt the bond. And of course, we enhance and we give to this bond more growth factors. So you can see here the stability of this bond. So we adapt everything and we go with the titanium mesh. Here we combine 2 titanium mesh because the space it's big. And we fix these 2 titanium mesh in the screw of the 10th screw. And we move this titanium mesh to the palatal and fix with 2 fixation screw. PRF to enhance the soft tissue healing. Since I use this titanium mesh with these small rolls and this is small perforation, you don't need a collage membrane over the titanium mesh, because they have the capacity to avoid the soft tissue growth and to promote stability. So we can see here the stability of the flap. And in the end of the video, you're gonna see the bone volume that we gain. So this is we gain around 5 millimeters, and this is Caio and Gisele that I told you. So we have a lot of cases on this. You can see here, just to be more quickly, I'm gonna show you the cases. So we can see a little explosion in the left part of the titanium mesh. Nowadays, I start to place 2 screws in the lateral of this in this titanium mesh approach in order to avoid this, because the tendency of this titanium mesh, it's trying to open it. So I fixed in the lateral also part or with a screw, with a pin, and this is the amount of bone that we gain. So in some parts 5.5, in another part 5.7. This is when we open. Okay, we can see here in the right of the screen part of the titanium mesh that start to open. This is the amount of bone that we gain. This is the amount of bone that we gain. And this is the baseline. And now we have, again, around 7 millimeters of bone that we can place implants. And a lot of cases using this kind of approach and with the same kind of result. So we can see here, this is 5 months, 7 months, no, 6 months after surgery. We can see here the amount of bone that we gain. Okay, normally we start to always use this 10 screws approach, because we can see here that we can have a good fixation of this titanium mesh, so we avoid the micro movement that these barriers could have. Okay, and we can change this reality in the baseline. We can see that we have around 0.87 thickness of the bone, and now we have around 5.4.5. That means it's a good bone gain, even in an area, in a very difficult area, on the thickness of the bone was so thin in the baseline condition. So you can see here how much bone that we gain. We can also do this in the posterior area of the mandibula. So just to see a case, you can see here in the CBCT tomography the bone defect that we have. So we can see, and we start to measurement this flap. Okay, one of the secret of this flap, it's to have and to move to work in the lingual flap. So normally we work in the myloid muscle insertion in order to enhance the size of the fibers, and we can see here that we can have a good movement and a good shape of the lingual flap. We call this coronally advanced lingual flap. So we can see here with gentle movements and traction with a blunt instrument in a coronal direction, we can enhance and we can grow the fiber of the muscles. So again, doing this, we have this kind of condition. Normally we use, because here we need to have a vertical bone gain. So normally we use 2 10 screws, because we can fix again the titanium mesh in this area like this. We close the flap, and here we can see that we gain around 3 to 4 millimeters. Now we have like 6 millimeters in thickness and 14 millimeters. So again, we can place different size of implants with a good quality in this posterior area of the mandible. Okay, so when I go to the literature, we see that normally we're using titanium mesh. We gain around 4 to 5 millimeters in terms of vertical and horizontal bone gain, and the mean exposure rate is around 16%. And trying to, and now at the end, we have more 15 minutes to show you one case using a sausage technique. A sausage technique, it's pretty the same principle of the titanium mesh, but instead to use a non-resorbable membrane, we use this soft membrane, this collage membrane. But again, the stability of this membrane should be one key and important issue to my bone reconstruction. Okay. This was the first clinical series analysis on this kind of procedures was published by Stephen Urban in 2011. And the principle that they normally said in order to say and to indicate the sausage technique, it's because the resorbable membranes present a better soft tissue compatibility, and again, maybe it could be have a lower rate of expulsion. And we know from the literature that this is a little bigger, lower, okay? But again, it's around 10%. If we come back and remember that I said about titanium mesh, it's around 16%. So it's not a big difference since we have a good curve of learning in both techniques, okay? But again, in this paper, Stephen Urban showed to us that we have a bone gain around 5 millimeters, again, mainly in terms of horizontally bone gain. And normally when we work and we need vertically bone gain, we choose this kind of membrane when we need almost 3 millimeters of bone gain in a vertical dimension, right? So again, this is a very important thing because, and we can see here that this membrane should be a good stability. We're gonna see in the end of this video that I'm gonna stick this membrane and the stability. We can't not cut normally this membrane with our hands, so we can fix, we can push this membrane, and again we can have a good stability. So we can see here in the end of this video, so that we have a good stability of this membrane. Okay, so this is a membrane from pericardium. This is a bovine membrane. We have again bovine and normally porcine sorts of these membranes. So this integrity of this membrane, it's a key point to use it. So we can see here a case. This is Natalia, a very young human. We can see here that she has aesthetics complaints about the implant that was placed 3 years before. Okay, so our decision here was to take out these implants, to do a GBR, and after to place an implant. When I saw this soft tissue, we can see here in the marginal area of this implant, we don't have keratinized tissue. So before to decide and to do our GBR, we decide to do a soft tissue measurement. So we can see here the loss of volume. We can see the baseline condition, the thickness is a thin periodontal phenotype, no keratinized tissue. This is the condition after take out the provisional crown. So we do a tunnel technique here. So we can see we do our tunnel in the 2 contralateral tips. We're gonna discuss more these details next week in our last webinar. But again, the details of this case we're gonna about the soft tissue measurement in another time. So we harvest a tissue from the palate. Normally we take out a free gingival graft and take out the epithelium outside of the mouth. Okay, like Zucchelli proposed. We fixed the soft tissue. Okay, you can see here. After we use and replaced again the provisional crown, we adapt this critical and the marginal part of this crown in contact with the soft tissue in order to have a good stability and a good space for this soft tissue. And we normally use a double cross suture proposed by Dr. Otto Zur for mucogingival surgeries. Okay, so this is our early healing, 21 days. This is with 2 months. We can see here the baseline. We can see here 3 months after. We can see that we increase the soft tissue. Now we have a good quality of this soft tissue for my GBR. Okay, here it's 3 months, and now we decide to do our GBR. Okay, so this is the position of the implant. It's again, it's an error of the planning treatment that caused this kind of condition. After open the flap, and in this case, when I'm working with a small defect, bone defect, I didn't open a vertical incision, just an envelope in order to have a better blood vascularity and support for my bone graft and my regeneration area. So I just do some split flaps in the interproximal papillas. So after remove the implant, we have this bone defect. So we decide to do a sausage technique here. We can see here that we have a two-wall bone defect. And we have around 5 millimeters, and we need to gain around 5 millimeters of bone gain in vertically. So we fixed this collage membrane. We can fix this with pins. It's better to fix it with pins. But here in Brazil, we don't have good pins to use. So normally I use these screws, but it's in small screws. It's around 1.2 millimeters to 3 millimeters. So it works like a pin, okay? So a bone graft, a particulate bone graft, and we fixed this in the palatal. So we can see here that we have a good stability of this bone. We also have to try to move this bone area. And if you have some little movement, we need to fix more this collage membrane. This is not the case here. And we do our sutures. This is 21 days after. We do like some adhesive crowns, okay? This is 6 months later. We can see here in the left part of the screen how amount bone gain we have in horizontal and in vertically. So we decide to place the implant, but look the quality of the bone graft, the soft tissue volume, sorry, the keratinized situation that we have. And if I decide to do this regeneration and do not do a soft tissue measurement, normally I don't have this quality of soft tissue. So sometimes it's important to go one step back. So we can see here how amount bone we gain 7 months later. And here we decide to place the implant. So this is the implant. We have a good primary stability. So we decide to also to place a provisional crown immediately. We do a soft tissue measurement in order to enhance the support of the interproximal papilla like this. So we graft a soft tissue and we placed the abutment through this soft tissue, and we also placed another soft tissue in the subcritical area of this provisory. We can see here, and we do our suture. This is 1 month after the surgery. We can see here that the interproximal papilla are still forming. We need to have patience in this time and wait around 3 to 4 months. And normally we will have this papilla, and after that we're gonna work in the definitive crowns of this patient. So based on this, I trying to show you some cases using resorbable and non-resorbable membranes, and try to do some guidelines on this issue. But again, we need to understand what we have from the literature, right? And this is a very recent paper published for a group from Egypt, using and comparing the sausage technique and the titanium mesh technique in the anterior part of the maxilla. In this case, they used a combination of 50% of xenographic bone and 50% of bone chips, autologous bone, and they didn't found any difference between techniques. Both groups using a collage membrane in a sausage technique, okay, or using a titanium mesh, they promote similar bone gain, around 3.9 in the collage membrane and 3.4 in the titanium mesh. But no statistically significant difference was observed between groups. And even in the histological analysis, they didn't found any difference between treatment. So both treatment okay, are good approach for our patient. But again, when we have and when we need more stability of your bone graft, normally our first option should be a non-resorbable membrane. Okay, and again, how amount bone again we need, more stability we need. So this is one rule that we can have in mind when we decide which kind of membrane we need to choose. Okay, about the using here, it's a paper comparing two different approaches using a titanium mesh or a PTFE membrane, right? Because we have a lot of papers using these dense PTFE membranes, and we have a lot of paper using titanium mesh. And in a clinical point of view, and in a histological point of view, again, no difference was observed between which kind of membrane or non-resorbable membrane we decide to use. If you decide to use a titanium mesh or if you decide to use a dense PTFE with titanium reinforced, right? So both are good. And again, the curve of learning in this kind of approach, it's a critical step in order to decide which one do you want to choose. And again, the patient and the bone defect, it's another key point in order to decide in type of membrane we need to choose. Okay, so in conclusion of this webinar, I always use the statement of the recommendation of the Guided Bone Regeneration. It's a consensus report published in 2016, right? In this paper in Implant dentistry, that I think that it summarizes all of the aspects of this webinar. So to avoid complication and to optimize our outcomes, some factors should be considered by us, right? The patient selection, the analysis of the defect type, the blood supply of my flap and my bone grafting, to have a flap free tension, a flap mobility, to understand if I would do a delay or simultaneously implant placement. When it's possible, normally we can do both together. The combination of the amount of combination of bone and xenograft should be also be analyzed, depends of the potential of the regenerative defect, a rigorous fixation of the membrane, and again, waiting around 6 to 9 months to do our second approach if you decide to place the implant after. So to wait this time of healing of this bone graft, and of course, analyze the complication. But sometimes we need to do soft tissue measurement, like I said in the case of Natalia, and of course, to have cares, a higher care in scarred sites, and of course, in the static area. When a combination of these factors, our chance is better. When I don't care in all of these factors, normally you're gonna fail. So bone reconstruction, it's again a very nice approach, a very successful procedures, very documented in the literature, and we need to know how to deal and how to work with these procedures. So I would like to say thank you to my team. This is a work of a lot of people, my students in university, the professor that work with me in Guarulhos University. This is my email if you have any question, if you can answer any question here in the webinar. This is my contact in the Instagram. You can also send me a directly, and I can answer if you have any doubts. So again, I would like to say thank you for this opportunity to share these cases and this this knowledge with you guys. Thank you so much.
Thank you, Professor Marcelo, for such an excellent presentation. You know, you did an excellent job in presenting these beautiful clinical cases and give us a good summary of some of the key factors to have a successful outcome when we're using, you know, bone regeneration. Now, there is some couple of questions, particularly in terms of the using of the titanium mesh. And you know, one of them is like, besides having a primary closure, as you mentioned, one of the key principles in achieving a good outcome, what other clinical hints to avoid exposure? You know, exposure of titanium mesh. Is there any clinical hints that you would give, and how would you manage the exposure of titanium mesh?
So the first thing that I think about the titanium mesh to avoid some complication is to analyze the soft tissue, the thickness of the soft tissue. Okay, if the thickness of the soft tissue it's very thin, okay, no keratinized tissue, normally my experience is to do a soft tissue measurement before. So normally I do like, I never do in the anterior part of the maxilla free gingival grafts. We know that free gingival grafts is the best approach to increase keratinized tissue, but when we do this, we have a lot of fibrosis in our periosteum. So normally I do like a vista technique, a vista incision, so a lateral incision, and I do like a tunnel, and I place the soft tissue in this tunnel in order to increase, okay, the thickness of the gingiva, the periodontal soft tissue, and I'll wait around 3 to 4 months, and after that I procedures with the titanium mesh. But I can show you here. Yeah. So we have here a late exposed, right? We have this it's a very complicated area because it's a static area. So we have, in this case, a good clinical outcome. You can see here in the tomography and the clinical, right? And what normally I do here, it's like this. I use a collagen matrix also, right? So I fixed it with sutures in the periosteum, in the apical part of the periosteum, in the my palatal flap, this collagen membrane, and I move back my flap and I leave this area of exposition, because here we're gonna have like this. This is 14 days. So we have the healing of this exposition. Of course, we don't have here, if you have suppuration, if you have infection in this area, it's another way of thickness, because we need to go to antibiotics. It's a more complicated situation. But in this case, we don't have infections. We just have the exposition of the titanium mesh. Even in the anterior part of the posterior part, we normally use this kind of approach.
Okay, now there is, just keeping on ourselves on the same topic, when in majority of the cases, when everything goes all right without complications, when do you usually remove the titanium mesh?
Normally around, when a combination with autologous bone, okay, even 30% or 50%, normally I wait around at a minimum of 6 months. Minimum. If I have a patient with more age, more older, normally I wait around 7 to 8 months.
And when do you place the implants? Is it at the same time you remove the titanium?
No, normally at the same time. It's not a rule on this. I know some friends that they prefer to open, take out the mesh, close the flap, and 1 month later place the implants.
Yeah.
Okay. I prefer to do at the same time because it's just one surgery.
The procedure. So in some cases, you cover the titanium mesh with resorbable collagen membrane, and in other cases, you don't. Is there certain factors that you consider when to use the resorbable collagen membrane to cover the titanium mesh, and when you don't use it?
Okay. In the most part of this case, I use a titanium mesh with a small perforation, right? Around 0.15 millimeters. When we have titanium mesh with a bigger perforation, and you have different in the market, right? Normally with this big perforation, we also need a collagen membrane in order to not stabilize the graft, but to avoid soft tissue ingrow cells to your graft area. So the most important point of this titanium mesh that I show you is that this titanium mesh can have the qualities of a non-resorbable membrane in terms of stability, and also the quality of a good barriers in terms of soft tissue enhance. So this is the reason that normally I use it.
And in terms of your choice, Professor Marcelo, I know there is really not enough evidence in the literature, but do you prefer the cross-linked collagen membrane or the non-cross-linked collagen membrane, and why?
My preference, it's not. It's a membrane without a cross-linking. Okay, because there's, like you said, there are not enough evidence about it. But there are some studies that show us that the amount of bone gain, when you compare a membrane with a cross-linking with a no cross-linking, normally we have better results with a membrane without a cross-linking. So based on this, my preference, it's a natural collagen that is normally in the pericardial membranes.
There are some technical questions here. Sorry, Prof. Marcelo, what type of sutures do you prefer to use?
Should be like, normally we use maintenance sutures, okay, vertical, horizontal maintenance sutures, 2 or 3, depend of the area. And after that, we use simple sutures. And normally I use a polypropylene instead nylon.
And you keep it for 2 weeks or more?
Normally we keep these 2 weeks. 2 weeks, it's enough, okay? But with this kind of suture, if you want to wait 1 week later, using 3 weeks, it's not a big problem. Normally I use a 5-0 suture, okay? So we can leave this 14, 21 days with no problem for our patient.
And in the first case, Professor Marcelo, the one with, I think vertical augmentation where you use the titanium mesh and the resorbable collagen membrane, you mentioned that you had 70% xenograft and 30% autogenous bone particles.
Yeah.
Where was the source of that autogenous bone particles? The ridge was so thin. Did you obtain it from somewhere else like the ramus, and you, I mean, the 30% of that autogenous bone particles in these situations, where do you get it from?
Normally we get from the cheese. Using like a vertical incision, and we use a ACM drill, and we can get fast this autogenous bone. And these are autogenous chips.
Yep, and there is one question.
And when I need like 50%, I go to the retromolar area because we have a more amount of bone.
More amount, okay.
Yes.
There is one, just to lay out these questions on about the age. I mean, does the age is a factor in considering more percentage of your autogenous bone particles, or age is not a factor in terms of the percentage of the mix?
Actually, we don't have literature to support this. Okay, but it's a clinical consensus that when more older is the patient, normally we goes more close to the 50%. But again, this is just a clinical opinion. We don't have literature to support this. And all of the studies that trying to correlate this normally don't have or don't found correlation on this. So again, it's like more a clinical opinion than evidence-based technique and support.
One last question, Professor Marcelo. When using the tenting screws, one of our colleagues is asking, is always your preference to use the titanium mesh, or do you use the high-density polytetrafluoroethylene as well? And what is your preference when you use tenting screws for vertical augmentation, and why?
You can use the tent screw in both situations. My experience, it's more related to titanium mesh, because this is what we have more here in Brazil. Okay, the dense PTFE arrived here in Brazil 2 years ago, something like that. So I have more experience using titanium mesh, but again, based on the literature and the last paper that I show you, it's compared titanium mesh and dense PTFE, and both works well in terms of exposed, in terms of bone gain, and in terms of histological analysis. If you have a good experience, in both, you can choose anyone.
My apologies, colleagues. We cannot answer all the questions, but as Professor Marcelo kindly provided his email, you can send the question to his email. I would like to thank Professor Marcelo for sharing his knowledge and expertise. We all enjoyed your presentations. I would also like to thank Index, ADIC, and Waterfalls for their efforts in organizing such an amazing webinar. From Dubai, thank you, colleagues from all over the world, for attending this webinar. Stay safe, everyone. Enjoy the rest of the day. Thank you again, Professor Marcelo. Bye-bye.
Thank you so much. Bye-bye.